Good morning, good afternoon, and good evening, depending on wherever you are. I hope you can hear me clearly. My name is Anafi Mataka from the African Society for Laboratory Medicine, and I'm delighted to be your host today. As we are about to begin, Sorry, I think you need to go to the French channel, Stephanie. Good. All right, I think we can continue. As we are about to begin, I just wanted to take us just a few moments of silence. I've just received a sad message that one of our regular interpreters on this platform, Odile Mokeba, unfortunately passed away last night. So just out of respect for her and in honor of her, maybe just a few moments to remember her. Right. So today we are going to be talking about an important subject that you have probably seen in a lot of media that has come through in the past few weeks, which is the outbreak of monkeypox outside the endemic regions of West and Central Africa. As we all know, the continued movement of people globally is unavoidable in present-day world, and that obviously carries a potential for spread of infections. And we have seen this unexpected outbreak of human monkeypox in many parts of Europe, the Americas, and Australia, which began May 7th, 2022, and has continued to spread at a relatively faster rate than anybody could have anticipated. I was just reading one article by Alimuddin and colleagues, which was on the Lancet, published on the 27th of May. They mentioned a key number of points that we need to take note as we look at this potential, as we look at this outbreak that we have in our hands. They realize that there are more and more cases that have been detected outside the endemic regions than what has been actually discovered in a long time in the endemic regions themselves, which is also cause for concern to the rapid spread of these cases. They also found that although there was some link, but there are no substantial links of travel to the endemic Africa for most other cases that are being detected, which would actually mean there is some undetected spread that has been happening through and through. They've also realized that the rapid spread, given that the virus, the monkeypox virus, is actually a DNA virus, which is expected to be relatively stable, has been spreading a little bit faster. So there is always a query potential that could this mean that viral transmission patterns or virulence has changed? These are still questions that need to be answered. In addition to that, there has been intense media coverage, and the hype has already gotten us, all of us, asking what is it that is at our hands. But one thing that we know with any outbreak is just like this one, we still have so many questions to answer. Questions around viral transmission dynamics. The disease epidemiology clearly shows that we need to be prepared. But however, we are not saying this is an emergency. I think that's what we want to also try to make sure that we are not yet in the emergency mode that potentially everyone might be thinking of. I think this is something that has been on our hands. A lot still need to be known. But one thing of priority for all of us is obviously to stop this spread of this disease. I just want to give, before we move on to the presenters today, logistic notes for what is going to be happening today. We have our 1 hour long session as usual, which shall start with 2 presentations, and then we'll go into a question and answer segment. I'd like to introduce 2 presenters who are going to take us into this presentation that we say mostly is on informational basis, because many of us have been having questions that probably need answers. So hopefully we'll get them today. So today I have Dr. Jacqueline Weyer, who is the principal medical scientist at the Center for Imaging and Zoonotic Diseases, National Institute of Communicable Diseases, which is a division of the National Health Laboratory Service, NHLS, in South Africa. She is part of the team leading investigations from diagnostics and research in human rabies, viral hemorrhagic fevers, and other emerging zoonotic diseases of concern for the South African public. For the past 10 years, she has authored and co-authored more than 60 scientific papers in peer-reviewed journals, including 7 chapters in books, and achieved a National Health Research Foundation C2 rating in 2017. Dr. Jacqueline serves on several national and regional committees working groups pertaining to laboratory biosafety and biosecurity, rabies and other zoonotic diseases, and One Health. She has been co-chairing the National One Health Forum in South Africa since its inception and a member of the National Rabies Advisory Group since 2008. So Dr. Jacqueline will give us the initial presentation, following which we will go into another presentation by Professor Mbala, whom I will introduce just before we begin the second presentation. Dr. Jacqueline, over to you.
Good afternoon, colleagues. Thank you very much for this honor to be here with you this afternoon, and for us to have this important discussion. So I was asked to do a presentation on the diagnosis of monkeypox and what the implications are for Africa. So firstly, again, just to echo what Nafi has already summarized, currently we are dealing with a multinational outbreak of monkeypox since the first week of May 2022. This situation is very quickly evolving, and currently most of the cases are reported from several European countries, the United States of America, Canada, Australia, and recently also the United Arab Emirates. The very first case that has been identified so far, so the earliest case in this outbreak seems to be an individual that was diagnosed with monkeypox on the 7th of May in the United Kingdom, and he did have a travel history to Nigeria before becoming sick. The good news of this outbreak is that so far there has been no fatalities associated with these cases. What's important to note is that we are concerned about this outbreak because it's the first outbreak of monkeypox to involve cases simultaneously from various non-endemic locations around the globe. And it is already the largest outbreak of monkeypox recorded outside of the endemic locations. So what is really important now is that we are prepared to deal with any such cases coming to our countries. And the goal is really for improved surveillance, case investigation, and contact tracing so that we can break the chains of human-to-human transmission and interrupt the outbreak. Of course, laboratory testing and confirmation or investigation of cases is a very, very important part of the containment process. So just a summary, again, this is a quickly evolving situation. There's just an error on the first line. It's 27 countries with 780 lab confirmed cases. You can ignore the 377. I've had to change these slides almost daily. So there was an error that came in there. So we are looking at 780 laboratory confirmed cases. It seems that the WHO has stopped reporting suspected cases. I think it's becoming very confusing. And then, as I've already mentioned, no deaths reported yet. 88% of these cases are reported from the European countries. By far, most of the cases involve males, of the age 20 to 59 years. There are a number of these cases that are individuals that are part of the community of men that have sex with men. So it's an infection that is spreading within this community. And there's also links to large social gatherings in several locations, which could have served as super spreader events of this virus. So several cases have been characterized genetically so far. And what we see is that all of these cases that have been analyzed to date belong to the Western African clade of the monkeypox virus. So it does point towards a single source introduction of the virus with this perpetuated human-to-human spread. At the bottom of the slide, you can see the number of confirmed cases per country, roughly in alphabetic order. Most of the cases coming from the UK, but also a large number of cases in Spain and Portugal. So if we want to understand monkeypox, let's talk a little bit about where it comes from and what we know about it. So monkeypox virus is a member of the orthopox virus genus of the family Poxviridae. Interestingly, it's quite a large group of viruses and more than 80 known viruses currently. And many of these viruses are very host restricted and infect very specific species of mammals, birds, reptiles, and insects. Likewise, there are pox viruses that we've find in humans only. This includes the smallpox virus, which we know has been eradicated. So this is not anymore a current health concern. And then also the molluscum contagiosum virus. There are then a number of pox viruses that can spill over from animals to humans. And in some of these cases, you can then find also human-to-human transmission. Examples of this includes cowpox, buffalo pox, the ORF virus, which you can find in goats, and you often find cases of ORF in farmers or people that deal with goats, and then of course also monkeypox virus. So the monkeypox virus is, as we said, a zoonotic infection, although the natural host of the virus is not confirmed. It's believed to be forest-dwelling animals because the initial cases of monkeypox in humans, at least, were identified in individuals with a contact history or within the context of tropical rainforest areas of Central and West Africa. So you can see on the screen, on the left, there's a list of the endemic countries. And on the right-hand side, you can see a map, and with the brownish color, an indication of where these endemic cases are reported from. There are two distinct genetic clades of the virus, and this is important, and I'll tell you why just now. So we see the Central African strain, which is thought to be a more severe strain. It's associated with a higher case fatality rate, and it's possibly also more transmissible based on anecdotal data. And then there's the Western African strain, which is then the lower case fatality rate of about 1%, and what we are seeing in the cases in the non-endemic countries currently. Interestingly, Cameroon seems to be the pivot for the distribution of these two genetic clades. And we find both clades within Cameroon, but only the Western African clade on the western end of Africa, and then the Central African clade in Central Africa. So these are the numbers of cases of monkeypox that are reported from the endemic countries in the past 6 months. In red, you can see the confirmed cases, but you can see, for example, in the DRC, quite a large number of suspected cases in that country. You can also see from the DRC higher case or higher fatality rate than what we see in some of the other countries. And this is to do with the genetic variant of the virus that's found in this country. Historically, if we look at the numbers reported over the years, one can also see that monkeypox is truly a fairly rare disease in humans, with few cases reported over the years. So apart from distribution in the endemic countries, there's been several instances of exportation of the virus to non-endemic areas. Our first encounter with, or when monkeypox became known to modern science, was when it was discovered in laboratory monkeys in Denmark in 1958. Then the first instance of an outbreak of monkeypox outside of Africa was in USA in 2003, where this outbreak was linked to the exotic pet trade. So there were several species of rodents in particular that were exported from Ghana. They were co-housed with prairie dogs, which is also a rodent-like animal, which is kept as a pet, sometimes in the US, and then through the distribution chains and people then acquiring these animals as pets, there were several human cases reported in the USA. Then you can see from 2018 up until this current event, there's been several exportations of monkeypox outside of the endemic areas. In Israel, in 2018, in the UK, there were actually 4 unlinked introductions, 4 cases, a case in Singapore, and 2 cases detected in the USA. In all of these cases, linkage could be made to travel to Nigeria. What's important to note, in all of these exported case events, there was 100% recovery of cases. If we look at the transmission cycle of the virus, there is the initial zoonotic spillover into the human population, and then following the spillover, there can be person-to-person transmission, which is what we are experiencing at the moment. So the first human case was actually noted in the DRC in a child in 1970. And then between 1970 up until 1980, only 59 cases of monkeypox in humans were detected. And this was all in close association with rainforested areas of Western and Central Africa. And these individuals all had exposure to different wildlife. So in all of these cases, there were reports of bites or scratches from different wildlife. There's also exposure through bushmeat practices, considering especially the slaughtering process, and also contact with other animal-derived products, for example, the skin or the leather or the fur of these animals, because these would also have the pox lesions. So again, as I've mentioned already, the true host of the virus is not known, but there's a number of different species that have tested positive for monkeypox before, although we're not 100% sure about the actual source of the virus. Person-to-person transmission, mercifully, this is not a highly transmissible infection in humans. It requires close contact. So it's not spread in a similar way as, for example, SARS-CoV-2 or the flu virus. It can be spread from face to face through large droplet transmission, but then also through very direct contact like kissing, cuddling, obviously also sexual contact, and then also, unfortunately, through contact with materials that have been contaminated with the virus. For example, if an infected person contaminates linen, clothes, or other household items, because the virus is fairly stable in the environment, there's a risk of contracting the infection through contact with these contaminated items as well. The secondary attack rate for the virus is fairly low, approximately 10%, but only in smallpox unvaccinated individuals. So in individuals that have previous history of smallpox vaccination, the attack rate is even lower. So for the clinical aspects of the infection, the incubation period varies in the range of 5 to 21 days. The infection manifests in 2 phases. Firstly, the invasion period, which can be very short, usually not longer than a week, where you will detect fever and the patient will be complaining of an intense headache. You will detect swollen lymph nodes, but there can also be back pain, body aches, intense weakness, and chills. Then 1 to 3 days following the onset of fever, one will start seeing the development of the characteristic skin lesions, which will make you think of monkeypox in the first place. So usually the lesions are concentrated on the face and the extremities, although it can be distributed on different parts of the body, including the palms of the hands, the soles of the feet. Oral ulcers are not uncommon, and then also lesions on the genitalia and the anogenital area is also reported. Localization of lesions are also often found. For example, cases where you only find the lesions on the hands or only find the lesions on the genitals, and there are different examples of that. On the next slide, I will show you a picture of the rash evolution. It's macules developing to papules, to fluid-filled vesicles, pustules with the yellowish fluid, and then these lesions will crust over and the scabs will fall off. The number of lesions can vary from very few. In some of the cases we are seeing in Europe, 2, 3, 4 lesions, so it can be very few lesions, which obviously makes diagnosis very difficult. But in more severe cases, you can see even several hundreds or thousands of lesions. Here are some pictures from the public domain that gives you an idea of what these lesions look like. Here you can see the progression of the lesions, as I've just explained, with when the scab falls off, and then the person, when all of the scabs have fallen off from all of the lesions, the person is no longer considered infectious. And here you can see pictures of the characteristic lesions. Very few in these cases, but you can see in some cases you can have a large number of lesions available. What one can also see is that all these lesions look similar, and that is something that we can use to distinguish between other infections, for example, chickenpox, where you will have lesions of that at different stages of progression at the same time. So with monkeypox, the lesions tend to start at the same time, and then they also have a similar appearance until they resolve. This is just to show the difference, for example, between chickenpox, as I've mentioned, lesions at different stages of progression. And this is a good example of monkeypox lesions, all of them looking very similar in appearance. So this is a self-limiting disease that can last, usually resolves within 2 to 4 weeks. Severe cases are usually reported in children, pregnant women, and individuals with underlying immunodeficiencies. There's a large differential diagnosis. You can see the list on the screen. It includes other viruses, but also bacterial and fungal causes of rashes. So it's important to also consider these because they would be more commonly occurring in our communities, And obviously, we don't want to be distracted from managing these cases appropriately because we are only concerned with monkeypox. This case definition, I'm going to just maybe skip over this with concern for time, but this is the current working case definition that's available from WHO, and you can find this information on the WHO website to apply in your respective countries. There are a number of antiviral treatments that may be useful for the treatment of monkeypox, but in most cases you will not need any specific treatment. And for example, for us here in South Africa, we don't have access to most of these drugs. So this is not necessarily an option for us. It may be different in your situation. For individuals that have had smallpox vaccination, there's probably some residual immunity because smallpox vaccination provides cross protection to monkeypox infection. So most countries stopped smallpox vaccination by 1980 because the disease was eradicated. So individuals in the age range of about early 40s and older should have been vaccinated for smallpox when they were young. Currently, we're looking towards we are looking towards the WHO for directive in how vaccination will be applied in this current outbreak, but also going forward in terms of mitigating the risks of monkeypox. This is the information in terms of the laboratory testing. The first line test is a monkeypox or orthopox virus PCR. Electron microscopy can be useful if available, but it's not the first line test. Sequencing capacity for positive cases are really important because this allows us to understand the linkage between cases, but also monitor for possible mutations of the virus, which may make it more transmissible or more pathogenic. Here's a summary of the samples that are recommended for submission, with the scab material or the lesion material being the most important for laboratory investigation. I'm going to take one more minute to finalize my presentation. I just wanted to show current available genetic inference for the outbreak. So most of these cases are clustering very closely together. It is within the Western African clade. So in this tree, you can see the Western African clade at the top, the Central African clade at the bottom. These cases that we are seeing now are very closely related. If you visit the NICD website, you can see some of the material that we have developed for use in our country for increasing vigilance and awareness in healthcare workers. Also the guidance on how to respond to suspected and confirmed cases. You will also find information about laboratory testing available at the NICD. Thank you. There's my contact details. If there's anything that you want to discuss in this respect, you're welcome to contact me. Back to you, Anafi.
Thank you, Dr. Jacqueline, for the wonderful presentation. Colleagues would like to move to the second presentation by Professor Mbala. So allow me to introduce Prof. Mbala, who is a medical doctor and PhD holder in virology, serving as the head of Epidemiology Department, Pathogen Genomic Laboratory, and Director of Clinical Research Center at the National Institute of Biomedical Research. He is also the operation manager of the PALM project collaboration between NIID and NIH and INRB in the DRC. Dr. Mbala has more than 10 years of experience working with viral zoonotic diseases such as Ebola and monkeypox, focused on clinical research studies, passive and active surveillance, as well as rapid response to outbreaks by these diseases. Professor Mbala, over to you.
Donc, je peux commencer avec ma présentation. Donc, je vais présenter quelques opportunités. Hein. Donc, je vais commencer par une petite historique et après, je présenterai une liste de quelques opportunités que nous pouvons avoir, soit en Afrique centrale, en Afrique de l'Ouest, des opportunités de recherche. La diapositive suivante. Alors, Jacqueline a bien rappelé que le premier cas de monkeypox humain a été détecté en République démocratique du Congo. Et ce cas est arrivé au moment où la communauté internationale était en train de travailler pour pouvoir éradiquer la variole. Et donc, c'était important de voir si le monkeypox qui a été détecté pouvait remplacer la niche écologique qui pouvait être laissée par la variole. Et donc, l'OMS a pris cette histoire au sérieux et a conduit une surveillance active. Et sur votre écran à gauche, vous pouvez voir l'image de la prime qui était donnée à toute personne qui pouvait découvrir ou notifier un cas de monkeypox à l'époque en République démocratique. Donc au Zaïre, donc c'est qui est la République démocratique du Congo. Et cette surveillance avait été menée dans plusieurs provinces en République démocratique du Congo et aussi dans plusieurs autres pays où il y avait quelques cas de monkeypox notifiés. Diapositive suivante. Alors, la conclusion de cette surveillance qui a été menée entre 81 jusqu'au 86 était telle que le monkeypox ne pouvait pas se maintenir dans une population humaine, non, parce qu'on a vu le virus était très peu transmissible. Et donc, on se disait qu'au bout d'un certain moment, la maladie pouvait s'éteindre de soi-même. Mais curieusement, en 96-97, il y a eu une grosse épidémie de monkeypox dans le Congo. Diapositive suivante. Et cela a amené la communauté internationale à pouvoir se poser des questions. Diapositive suivante. Oui, donc cela a amené la communauté internationale à pouvoir se poser des questions. Qu'est-ce qu'on sait exactement sur cette maladie? Est-ce qu'on connaît exactement le fardeau de cette maladie dans nos populations? Est-ce que les facteurs de risque ont changé par rapport à ce qui était rapporté lors de la surveillance active en 1980? Est-ce que le virus est devenu plus transmissible? Ou bien est-ce qu'il y a évidence que vraiment ceux qui ont été vaccinés contre la variole pourraient être protégés à long terme? Et c'est sur base de ces différentes questions que en 2002, avec l'Université de Californie, Los Angeles, l'INRB a conduit une surveillance active du monkeypox dans la région de Congo. Diapositive suivante. Et c'est pratiquement dans la même région que la surveillance active avait été réalisée par l'OMS. Et c'est que cette étude a révélé, diapositive suivante, et cette étude a révélé que l'incidence était beaucoup plus importante que l'incidence qui avait été prédite lors de la surveillance active de monkeypox entre 1981 et 1986. Et cette incidence qui a été rapportée lors de la surveillance entre 2002 jusqu'à pratiquement 2007 était de 20 fois plus élevée que la prévalence ou pas que l'incidence qui avait été prédite par l'OMS. Diapositive suivante. Et on a remarqué que l'incidence était beaucoup plus élevée dans la région qui était dans la région forestière. Diapositive suivante. Et cette incidence était beaucoup plus élevée chez les personnes jeunes. Donc, comme vous pouvez le voir sur ce graphique, donc en orange, et cette incidence régressait au fur et à mesure que l'âge augmentait. Et là, on a vu que les personnes qui étaient... donc, l'incidence était beaucoup plus élevée chez les personnes qui étaient nées après l'arrêt de la vaccination contre la variole. Diapositive suivante. Et au cours de cette étude, on a pu montrer que les personnes qui étaient vaccinées étaient protégées pratiquement à plus de 80%, et ce qui est comparable à ce qui a été rapporté à peu près vers les années 80. Donc, on a montré que effectivement, les personnes qui étaient vaccinées dans 30 ans après étaient encore protégées parce que l'incidence de la maladie dans cette population était très faible. Diapositive suivante. Ainsi, il était important de pouvoir explorer les autres facteurs qui pouvaient avoir un impact sur soit la transmission de l'homme vers l'animal à l'homme, donc le spillover, ou bien ces différents facteurs étaient notamment la baisse de l'immunité collective avait un impact. Est-ce que dans le réservoir, est-ce que et qui pouvait avoir un impact, est-ce qu'il y avait une co-infection ou la malinfection, est-ce que le virus de transmission intergénique 86 lors de la surveillance active de l'OMS. Si nous avons mené une étude, diapositive suivante, étude observationnelle. Diapositive suivante. Diapositive suivante. Donc, nous avons mené une étude observationnelle à Collet, qui est également la zone où l'une des zones où la surveillance active de l'OMS avait été menée en 81 et 86, donc 30 ans après, pratiquement. Diapositive suivante. Et comme vous pouvez le voir, c'est un milieu qui est très reculé, qui est pratiquement en pleine forêt équatoriale, donc avec une incidence de monkeypox un peu plus élevée lorsqu'on compare aux autres zones qui sont dans les régions de savane. Et là, c'est le laboratoire que nous avons installé à Collet, comme vous pouvez le voir, avec avec la PCR, donc une machine de PCR des hôtes et également et au cours de cette étude, de manière journée donnée sur le nombre des lésions cutanées, et nous avons également recueilli des données de laboratoire, notamment l'hématologie, la biochimie, des données urinaires, la charge virale, etc. Et cette étude a été récemment publiée, et donc vous pouvez voir les différents éléments que je vais rapporter ici pour voir les détails dans l'article. Diapositive suivante. Et les participants ont été suivis pratiquement pendant 3 semaines. Et comme signe clinique important, c'est que nous avons remarqué lors de l'examen, c'était essentiellement les lésions cutanées et les lymphadenopathies. Donc, comme vous pouvez le voir, les ganglions, les lymphadenopathies étaient pratiquement l'élément aussi caractéristique à côté des lésions cutanées pour le diagnostic clinique du monkeypox. Diapositive suivante. En plus, il y avait également, c'est vrai, de la fièvre, des malaises, etc. Mais sur le plan clinique, les deux éléments étaient vraiment caractéristiques de la maladie de monkeypox. Diapositive suivante. Et les lésions cutanées et la lymphodenopathie, c'était des signes qui perduraient pratiquement jusqu'au-delà de 18 jours pour les participants monkeypox positifs que nous avons suivis au cours de cette étude observationnelle, pendant que la majorité de symptômes duraient entre 3 et 5 jours. Diapositive suivante. Et comme l'a dit Jacqueline, donc, les lésions sont essentiellement centrifuges, c'est-à-dire commencent au niveau des extrémités. Comme vous pouvez le voir, il y a plus de lésions au niveau de la tête, donc tête et face, et aussi au niveau des mains et des pieds. Et ce sont des lésions qui pratiquement envahissent les paumes de main et les plantes des pieds. On commence avec la varicelle, mais pendant le varicelle avec des lésions au niveau des paumes des mains et des plantes des pieds. Donc, c'était vraiment de cas de varicelle atypique. Diapositive suivante. Mais ce qui est important, c'est que là, parmi les caractéristiques aussi de monkeypox, c'est essentiellement la lymphadenopathe qui apparaît habituellement au niveau de la région cervicale et aussi au niveau de la région inguinale. Diapositive suivante. Et nous avons également observé une corrélation importante entre les nombres de lésions cutanées et la sévérité de la maladie, comme vous pouvez le voir sur ce tableau. Diapositive suivante. Et sur le plan de la biochimie et de l'hémato, l'élément important, c'est que nous avons vu chez les patients qui étaient sévèrement atteints de monkeypox, avaient plus une perturbation de la fonction hépatique. Diapositive suivante. Pour ce qui est des lésions, des lésions cutanées, donc chez les personnes qui étaient moins atteintes, c'est-à-dire avec une forme modérée et bénigne, on avait une fluctuation de la virémie et on pouvait avoir également une virémie qui pouvait apparaître avant l'apparition des symptômes. Et chez les personnes qui étaient gravement atteintes, comme vous pouvez le voir, la virémie restait pratiquement au plateau jusqu'au moment du décès. Ce qui est important ici, c'est que l'IATIF qu'on pouvait donner aux patients et qui nous a pratiquement à 2%, il est important de pouvoir avoir des traitements spécifiques pour pouvoir contrecarrer l'action de ce virus dans l'organisme. Diapositive suivante. Voilà. Oh là là. Alors, je pourrais, pour raison de temps, donc je pourrais me limiter là. Alors, juste pour vous montrer les différentes complications que nous avons eues au cours de cette étude, c'est que là, vous avez les lésions confluentes à gauche en bas, donc une dermatite secondaire avec des lésions confluentes qui peuvent être purulentes. Nous avons eu le cas avec les lésions confluentes au niveau de l'œil, et nous avons eu également des cas de kératite. Et un cas de kératite, comme vous pouvez le voir au milieu, au-dessus, au milieu, un cas de kératite qui a donné un staphylome lorsqu'on a revu le patient pratiquement 2 ans après. Et on pouvait également avoir de cas d'œdème. Est-ce qu'on peut aller à la diapositive, à la dernière diapositive? Comme ça, je peux avoir le temps de terminer. Donc, on a eu également des cas d'avortement spontané. Sur les 5 femmes enceintes que nous avons suivies, 4 ont avorté spontanément. Chez un, on a pu voir qu'il y avait des lésions dans le placenta, des lésions hémorragiques et même des lésions sur la peau du fœtus, des lésions sur la peau du fœtus. Diapositive suivante. Diapositive suivante. Nous allons passer parce que, pour raison de temps, le monkeypox, essentiellement dans nos pays, se retrouve dans les pays, dans les coins reculés, et le diagnostic de laboratoire est très difficile, c'est que fait qu'on recourt très souvent à la définition de cas pour pouvoir faire le diagnostic clinique. Et il est important, diapositive suivante, de pouvoir faire le diagnostic de laboratoire pour pouvoir confirmer les différents cas. Et pour cela, il faudra recourir à la PCR et c'est le seul moyen pour le moment que l'on utilise pour pouvoir faire le diagnostic et le séquençage pour voir les variations génomiques et les mutations. Mais il faut noter qu'il y a d'autres analyses qui peuvent être également réalisées pour assurer une bonne prise en charge, notamment la biochimie et l'hématologie. Diapositive suivante. Et en termes d'opportunités, donc, notamment, il y a les essais cliniques que nous devons mener sur les vaccins et sur les médicaments. Et on ne sait pas encore exactement quelle est la portée des séquelles. Et on a besoin des études d'immunité de ceux qui sont atteints. On ne connaît pas exactement s'il y a eu des cas de réinfection, de réactivation. Il y a des populations chez qui on doit également mener des études, notamment les personnels de santé, les chasseurs. Il y a également des cas de co-infection qu'on doit explorer, notamment avec la varicelle, le VIH et les autres maladies qui sont endémiques dans nos milieux. Et on peut également penser à des études de génomique et également voir explorer la transmissibilité de la maladie. Et on continue également à faire des recherches sur le réservoir, les espèces qui peuvent être considérées comme le réservoir de cette maladie dans nos communautés. Merci pour votre attention.
Thank you very much, Professor Mbala, for the presentation. Very informative indeed. I'm going to quickly take a few questions. Thanks to Dr. Jackie, she has answered, I think, the majority of them in the chat. Interestingly, there are a number of questions that are asking about specimen collection. I know you have said, go to the NICD website. Maybe you could speak a little bit to the guidance around specimen collection. I saw also questions around use of viral transport media. Dr. Jackie.
Yes, the most important samples are the samples that are associated with the rash. So there are different samples that you can take. It can be just a swab of the lesion. It can be an aspirate of the fluid in the lesion. It can be the roof of the scab, or material from the scab area. So that's the most important sample, and if it's positive, there's lots of virus and the PCR wouldn't be a problem. Then the WHO also recommends that you can test blood, semen, throat swabs, swabs from the rectum and so forth. But I think these samples are reserved for positive cases, and it's really because we want to know more about, for example, is there virus in the semen? Is it really important for transmission, or it's just through contact with the lesion? So it's almost like it's more to answer some research questions. So for diagnostic purpose, it's the lesion and the material that you can collect from the lesion that's important. The question of the viral transport media keeps coming up. At the moment, the recommendation is that you can almost do anything and it should be fine because the virus is so stable. So even just the dry swabs without any viral transport media, that must or should also be fine. But there are studies or people looking, I know the people from CDC Atlanta, they are looking at, or they mentioned that they are looking at validation of different types of VTM, which one is better. So we don't have those answers yet, but I think because it's such a hardy virus, it's not very sensitive. You can do almost anything, even just send the dry scab in a tube and it should be fine. If the virus is there, it should be detected. So the most important test is the PCR. There are different assays currently targeting different genomic regions. There are monkeypox specific PCRs. Some people prefer to use the orthopox PCR because it allows you also to detect other orthopox infections. And maybe because we are so sensitive now for cases, we might be detecting more of those that we will usually just ignore. But then connected to the positive cases, as in both of the presentations we've discussed, the importance of sequencing. So commercially, there's not a lot of options currently, but as you can imagine, I think in the next couple of weeks, we will see some commercial assays becoming available. Over.
Thank you very much, Dr. Jackie. There are also quite a number of questions that are coming in the chat. There's this one from Chinenye Apo, who says, why are there so many cases in the DRC but little testing? Is it more of lack of testing capacity? So I want to throw this to Professor Mbala. Should we be worried more about testing? Just give us a guide, and what are the issues on the ground? Prof?
Yes, actually, I think the thing, yeah, can you hear me?
Yes, please go ahead.
Yeah, so I think right now the testing capacities are really, I can say, small in the country. This is the reason why there is a really small testing confirmation of the suspect monkeypox cases in the country. And as you know, most of those cases occur in a remote area, and DRC is a big country. So shipping samples from where the outbreak occurred to Kinshasa, where the only monkeypox surveillance lab exists, is really challenging. So this is the reason why most of those assessed cases are not confirmed. So only few of them are confirmed, and then the rest, most of them are clinically diagnosed. So this is why we are now working with the CDC to validate the gene expert for monkeypox, as now you know the gene expert is being used for the TB, HIV, and other program. That would be very easy to then bring the diagnostic on site.
Thank you very much, Prof. Then lastly, there have been so many questions around immunity. And then I remember one of the questions that came as a private message was whether the vaccination for smallpox also is protective for monkeypox. Would any?
Yes, I think even me or Jacqueline, we can answer. Jacqueline, I think she talked about it, saying that the people who are vaccinated are less, I can say, to get the disease. This is what we also showed in our study that we conducted from 2002 to 2011, and we showed that the incidence among the vaccinated people was very low. And so I can confirm that the smallpox vaccination protect against monkeypox.
Thank you very much. As usual, time flies. They say time waits for no man, even for a king. So it didn't wait for us. We have reached the end of our session today. I hope you found this very useful and you gained also knowledge. As we said, I think there's been so much hype around smallpox within the media, and we felt it was very important for us to come here on this platform as usual and be able to share and interact. A lot of questions in the chat. We will check the chat and see if there are many of them that are unanswered. We will kindly go back to Professor Mbala and Dr. Jacqueline to see if they can be able to answer this, and we'll be able to share with you. Questions around slides and the recording are going to be shared. You can also visit the ASLM YouTube, even the ASLM resources page to be able to find these slides. Give us at least 48 hours, you should be able to find them. Ladies and gentlemen, thank you again for joining in your huge numbers as usual. We look forward to future sessions. We will be having one on this Thursday where we will talk about electronic transmission of results, the case study of Zimbabwe. So looking forward to meeting you on Thursday. For now, stay safe, stay good. Bye-bye.